Dr. Achibong, Senior Registrar in Obstetrics and Gynecology at the Obafemi Awolowo University Teaching Hospital, Ile-Ife. I'll be giving a lecture on malpresentation. And these are the learning objectives of this lecture. At the end of this lecture, you should be able to know the predisposing or risk factors for the various malpresentation. You should be able to know how to diagnose the various malpresentation and how to manage appropriately the various malpresentation. We'll be considering 3 different kinds of malpresentation in this lecture. First will be breech, and then brow presentation, and then we'll round up with face presentation. But before we go to the various forms of mispresentation, we want to know some basic definitions in obstetrics as regards this lecture that will help us understand this lecture better. The first will be lie. Lie is said to be the relation of the fetus to the longitudinal axis of the uterus. So if the longitudinal axis of the fetus is parallel to that of the uterus, the lie is said to be longitudinal. If it is at right angle to that of the uterus, it is said to be transverse lie. So we could have longitudinal lie, we could also have transverse lie. Then presentation or presenting part. And this is the pole of the fetus that occupies the lower uterine segment and the cervix. And then position is defined by the relationship of the denominator of the presenting part to the fixed point on the maternal pelvis. Then denominator is an arbitrary or the most dependent part of the presentation that is used to denote the position of the presenting part with regards to the pelvis. So for breech presentation, the denominator is the sacrum. For face presentation, the denominator is the chin or the mentum. Then for attitude, attitude has to do with the degree of flexion of the head in relation to the other part of the body. Now, for us to say neighbor is normal, the line must be longitudinal, the presentation must be cephalic, vertex presentation to be precise, and the position of the fetus must be in the occipital anterior position. So if there's any deviation from any of these, it will lead to abnormal labor. Malpresentation is said to be any presentation other than vertex. So any presentation that is other than a vertex presentation is considered a malpresentation. Malpresentation generally associated with increased maternal and fetal risks. Some of the maternal risks that could be associated with malpresentation include prolonged or obstructed labor, infection, increased rate of operative deliveries, difficult vaginal deliveries, genital trauma, which can also lead to postpartum hemorrhage. It is also associated with certain fetal risks, and these risks could include neonatal infection, asphyxia, and also cord prolapse. We'll start with the first type of malpresentation I'll be considering, and that is breech presentation. Breech presentation is said to be the commonest form of malpresentation, and is said to occur when the caudal pole, that is the fetal buttocks or the fetal legs, occupies the lower uterine segment. The incidence of breech presentation actually varies with the gestational age. It is said to be 40% at 20 weeks, 6 to 8% at 34 weeks, and 3 to 4% at term. So it means that as gestational age increases, the incidence of breech presentation actually decreases. Now, what are the risk factors for breech presentation? The risk factors for breech presentation can either be maternal and fetal. The maternal risk factors include primary gravidity, multiparity, placenta previa or pelvic tumors, uterine anomalies like bicornuate uterus, previous history of breech presentation, and contracted pelvis. For primary gravidity and multiparity, the explanation for this as they contribute to risk factor for breech presentation is the fact that for a multiparous patient, because she has had numerous deliveries, the uterine muscle is said to be lax, and so the baby is at liberty to turn and assume various presentation as it deems fit. It is similar to primary gravidity. However, in primary gravidity, the uterine wall is not as relaxed as that of a multiparous patient. Therefore, whatever presentation that the fetus occupies, it is very likely that that is the same presentation that may persist even not to term. Whatever also occupies the lower uterine segments will be a risk factor for breech presentation. That is why placenta previa and pelvic tumors are risk factors for breech presentation. For the fetal risk factors, prematurity is a risk factor for breech presentation. And this is because at lower gestational ages, the head of the fetus is usually bigger than the other body parts. And because when we look at the structure of the uterus, the fundus of the uterus is usually bigger than the lower part of the uterus, and therefore the fetus will likely assume a presentation such that the head, which is bigger, will fit into the upper part of the uterus. And this is what is responsible for the increase of incidence of breech presentation at lower gestational ages. Multiple pregnancy is also a risk factor for breech presentation. Polyhydramnios or oligohydramnios are also risk factors for breech presentation. This is because in polyhydramnios, because of the excess liquor volume, there's enough space for the baby to turn and to assume various presentation. Fetal anomaly is also a risk factor for breech presentation. And it's commonly said that abnormal babies do abnormal things. So generally speaking, when we come across any malpresentation in obstetrics, we should always look for any form of fetal anomaly that could be a risk factor or contribute to the malpresentation that is being seen. What are the various types of breech presentation? There is the complete or the flex breech, there's the extended or the frank breech, and there's also the foot limb breech. Now, for the complete or the flex breech, I'm going to explain the relationship or the anatomic position of the legs for the complete or the flex breech. For the complete or the flex breech, there is flexion of the hip joint and also flexion at the knee joint, as shown in this diagram. Then for the frank or the extended breech, there is flexion at the hip joint and there is extension at the knee joint. Then for the foot limb breech, there is extension at both the hip joint and also the knee joint. I mentioned earlier that one of the complications of abnormal presentation is cord prolapse. And then for breech presentation, each type of breech presentation is also associated with a particular degree of cord prolapse. For the complete or flex breech, the risk of cord prolapse is said to be about 5 to 10%. For the extended or frank breech, the risk of cord prolapse is similar to that of cephalic presentation, which is about 0.5%. And then for the foot limb breech, the risk of cord prolapse is about 10 to 15%. And how do we make a diagnosis of breech presentation? Clinical suspicion is important for us to make a diagnosis of breech presentation. Usually for women with breech presentation, some women may complain of persistent subcostal pain or epigastric tenderness. This is not usually specific, but may raise our clinical suspicion of breech presentation. Some women may also complain of feeling the fetal kicks at the lower part of the abdomen. This can also raise our suspicion of breech presentation. However, for us to make a confirmation of breech presentation, ultrasound scan is confirmatory for breech presentation. Aside from the fact that ultrasound scan is going to confirm whether it is a breech presentation or not, it will also help us to determine the possible etiology of breech presentation. Because when an ultrasound scan is done, one can estimate the liquor volume, can rule out congenital anomaly, can rule out uterine anomalies in the fetus, uterine anomalies in the mother. So ultrasound scan confirms breech presentation and also help us determine the possible etiology that may be responsible for the breech presentation. Now, the management of breech presentation. Management of breech presentation depends on gestational age at which the breech presentation is noticed. Prior to 36 weeks, most women, if they have done a scan and they notice that the presentation of the fetus is breech, they may present to the clinic with the ultrasound scan saying that the fetus is in breech presentation. If these women present before 36 weeks, the right thing to do is to counsel those women and to reassure them that because the fetus is premature, there is a tendency for spontaneous version to cephalic presentation to still occur. So in such patients, one just counsels this patient and reassures them that there is a possibility of the fetus changing its presentation to a cephalic presentation. However, after 36 weeks, spontaneous version is rare. And when patient presents with this presentation after 36 weeks, we need to discuss the options of management with these patients. And what are the options of management for a patient with breech presentation? The first option of management is external cephalic version, called ECV. The second is the patient to have an assisted or a planned vaginal breech delivery. And the third is the patient to have an elective cesarean section. But currently speaking, it has been advocated and recommended by most international obstetrics organizations that all patients presenting with breech presentation should be offered external cephalic version. So currently, external cephalic version should be what should be offered for all women having breech presentation. Now, external cephalic version is done at 37 weeks. However, for non-Peyer's patient, it could be done as early as 36 weeks. External cephalic version is a procedure in which the fetus, either in breech presentation or even in a transverse lie, is converted to a cephalic presentation transabdominally. So the fetus is manipulated transabdominally from a breech presentation to a cephalic presentation. This procedure is not without its own contraindications, but however, these contraindications are majorly relative because the risks associated with external cephalic version with good patient selection has been said to be less than 1%. What are those contraindications to external cephalic version? Generally, whatsoever would be a contraindication to vaginal delivery automatically becomes a contraindication to external cephalic version. And contraindication to ECV will include placenta previa, preeclampsia, abnormal Doppler or CCG finding, multiple pregnancy, rupture of membrane, intrauterine growth restriction, previous uterine scar. But as I said earlier, most of these, particularly previous uterine scar, intrauterine growth restriction, they are said to be relative contraindication. And with good patient selection, this complication hardly occur. For external cephalic version to take place, there are some requirements that must be in place. First of all, the skill of the obstetrician must not be in doubt. So whoever is performing an external cephalic version must have been trained and adequately have the necessary skill for external cephalic version. And external cephalic version must be performed in a place where there is facility for cesarean section, because some of the complications that may result from external cephalic version may necessitate an urgent cesarean section. So it should be done in a place where there are facility and the skill for cesarean section. It must also be done in a place where cardiotocograph CTG is available. This is because before and after the procedure, the fetal heart rate needs to be monitored to ensure that the baby is fine. Another requirement for external cephalic version is the presence of ultrasound scan. It should also be done in a place where there is ultrasound scan, because this is because the external cephalic version in itself is done under ultrasound scan guidance. Now, what's the success rate of external cephalic version? The success rate of external cephalic version has been reported to be 50%. However, there are some factors that actually affect this percentage. The success rate has been said to be increased with tocolysis, multi-Peyer's patient, adequate liquor, flexed breech that is mobile above the brim, a posterior placenta, low maternal weight, amniotic fluid index greater than 10. These are some of the factors that increases the success rate of external cephalic version. So if the mother is overweight, if the mother is obese, there is a tendency that the success rate may decrease. What are the complications associated with external cephalic version? Some of the complications include preterm labor, abruptio placentae, cord accident, fetal-maternal transfusion, amniotic fluid embolism, uterine rupture, and rupture of the membranes. These are some of the complications that are associated with external cephalic version. Now, for the external cephalic version procedure, before this procedure is embarked upon, a cardiotocograph CTG needs to be done prior to the procedure to ensure that there is no fetal heart rate abnormality ab initio. Then the next thing that should be done is that the breech should be disengaged from the pelvis, and then the culture grabs the two fetal poles and turn the fetus in an attitude to maintain flexion until the head occupies the lower pole of the uterus. Then an ultrasound scan is done to confirm the new presentation. A cardiotocograph CTG is also done in order to confirm that there is no fetal heart rate abnormalities, and the mother should also be given rhesus immunoglobulin if it is indicated. That is, if it's rhesus negative, if the mother is rhesus negative, rhesus immunoglobulin should be given to the mother. This is because external cephalic version is considered a sensitizing event. Now, this picture shows the procedure of external cephalic version, in which the culture disengages the breech from the lower pole, and then a forward roll is attempted, and then the fetus is turned from a breech presentation to a cephalic presentation. And several studies have also been done concerning external cephalic version. One Cochrane review in 2015 showed that external cephalic version reduced the rate of CS and reduced the rate of non-cephalic presentation. And this is one of the reasons why it is recommended that all women with breech presentation should be offered external cephalic version as the first line option of management. There have also been some criticism about external cephalic version. One of the criticism is the fact that external cephalic version is associated with so much multiple risks and complications. And so some people argue that is it worth it to subject a woman to such risks and complications just because you want to perform an external cephalic version? ECV has also been criticized on the fact that it has little effect on the overall cesarean section rate. The incidence of breech presentation at term is said to be 3 to 4%. And so, even if all women that have breech presentation eventually have successful ECV, the overall effect on the cesarean section rate may not be statistically significant. Moreover, it has also been found out that there's a higher rate of cesarean section in fetus with successful external cephalic version. So it means that even after an external cephalic version has been found to be successful, the risk of cesarean section has also been found to be higher in these fetuses, because it has been found that these fetuses are at risk of having malposition and fetal heart rate abnormalities even when they fall into labor. The second modality of management for breech presentation is vaginal breech delivery. Now, for vaginal breech delivery can either be spontaneous breech delivery, it could be assisted breech delivery, and it could be breech extraction. Spontaneous breech delivery, this is said to occur when there is delivery of the breech without any assistance. This can only take place if the labor is unsupervised and is not recommended in modern obstetric practice. The assisted vaginal breech delivery is what is currently recommended, and it involves a vaginal breech delivery in which the fetal body is guided through the birth canal by a series of properly timed maneuvers. And then breech extraction, the whole fetal body is extracted by the acupuncture without the assistance of maternal effort. Breech extraction currently has little role in modern obstetric practice. However, it can be applicable when we are dealing with twin gestation, when we want to deliver the second twin with associated fetal heart rate abnormality of the second twin. For assisted vaginal breech delivery, once a woman has opted for assisted vaginal breech delivery, she should be counseled on the risks associated with assisted vaginal breech delivery. This includes the perinatal mortality, the neonatal morbidity, and for a woman to undergo assisted vaginal breech delivery, there are some criteria that must be met, and this includes that the breech must be a complete or flexed breech. The fetal weight must be average size weight. The pelvis must be adequate, and then the fetus must be in a good attitude. It must be a well-flexed head. For labor, induction of labor is controversial for patients with breech presentation. Augmentation of labor is also controversial. However, it has also been said that for patients who have poor contractions and are carrying breech presentation, the labor can actually be augmented. And for patients with breech presentation, when they are in labor, analgesia should be given to them appropriately. And also for patients with breech presentation should undergo continuous electronic fetal monitoring with the use of CTG. So breech presentation in labor is actually one of the indications for CTG in labor. Now, for a patient who has opted for assisted vaginal breech delivery, once the patient gets to the second stage of labor, the pediatrician should be informed. The anesthetic should also be informed that there's a patient that is about to undergo assisted vaginal breech delivery. And there's a principle for assisted vaginal breech delivery. And the principle for assisted vaginal breech delivery is masterly inactivity with observance to critical anatomical landmarks. In other words, for assisted vaginal breech delivery, the acupuncture performs appropriately timed maneuvers in order to deliver the fetus. And we're going to consider some of these maneuvers in the next slide. Now, these maneuvers are usually done when we come across certain critical anatomical landmarks. I'm going to quickly run through some of these landmarks. Once the anterior buttocks is seen, one should give a pudendal block. Once there's a bit of meconium on the anus is seen, episiotomy should be performed. Once the baby delivers up to the umbilicus, we should free loop of course to prevent cord compression. Once the hips is seen, the leg should be delivered. Once the inferior angle of the scapula is seen, it means that it is time to deliver the hands. And once the nape of the neck is seen, it means it's time to deliver the head. And these are the critical anatomical landmarks that one should consider before performing any maneuvers. And we're going to look at some of these maneuvers associated with breech presentation. The first maneuver is the peanut maneuver. It is usually done for to deliver the legs, particularly when the legs are extended. For a flexed leg, for a woman with a flexed breech that is undergoing assisted vaginal breech delivery, what one needs to do is just to flick out the legs, and the legs will deliver normally. However, if the legs are extended, then one may need to employ the peanut maneuver. And in the peanut maneuver, what happens is that one applies pressure on the popliteal fossa. This will cause the fetus to flex the knee, and so the knees are flexed and the hips are abducted and the legs are delivered. And then this maneuver is repeated on the other side and the legs are also delivered. So the peanut maneuver is the maneuver that is employed for delivery of the leg, particularly when the legs are extended. The next maneuver that is relevant is the love-set maneuver. The love-set maneuver is usually employed if for delivery of the hand, particularly if the hands are extended. If the hands are flexed, then one does not need to employ the love-set maneuver. But for the extended arms, then one needs to employ the love-set maneuver. In the love-set maneuver, the fetus is grabbed at the hip and then rotated through 180 degrees such that the posterior arm becomes the anterior arm, and then it is delivered, and then the baby is rotated 180 degrees in the opposite direction, and then the other arm is delivered. So the love-set maneuver is what is done to deliver the extended arm in breech presentation. Then, for a delivery of the head, there are two major methods that can be used to deliver the head and assisted vaginal breech delivery. The first one is the use of application of Piper's forceps, which is the forceps that is specially designed for delivery of the aftercoming of the head. And the delivery of the aftercoming of the breech is important because one does not want the head to deliver suddenly, because if the head is delivered so suddenly, there could be rapid decompression and it could lead to tentorial tears, which is what is called the champagne cork appearance in delivery of the breech. So the Piper's forceps can actually be used, which will ensure controlled delivery of the head. Another method that can be used in delivering the head is what is called the Mauricio-Smenivate maneuver. In the Mauricio-Smenivate maneuver, the fetus is made to lie slide the hand, the forearm of the acoucha, with the index finger and the middle finger placed on the malar eminences of the fetus, and then the other hand overrides the neck of the fetus. Then an assistant applies suprapubic pressure to put the head in proper flexion, and then with downward outward traction, the head is delivered. Now these maneuvers are important so as to avoid rapid delivery of the head, which could cause some complication. There are some special scenarios that may occur when conducting assisted vaginal breech delivery. One of those scenarios is what is called nuchal arms. This is when the arm is found behind the neck of the fetus. Now, when one comes across a nuchal arm in assisted vaginal breech delivery, what one needs to do is simply to rotate the fetus in the direction where the arm is pointing, as shown in the diagram, as shown on the slide. So if the fetus is rotated in that direction, the friction between the maternal pelvis and the head will push the arm in the opposite direction, and then the arms can be delivered. So the logic is to rotate the fetus rather, in the direction where the arm is pointing. Another maneuver that is useful for us to note for assisted vaginal breech delivery is the modified Prague maneuver. Now, this modified Prague maneuver is usually employed if the back is posterior. It's important to note that when conducting assisted vaginal breech delivery, the back should be facing superiorly. However, if the acoucha is not properly trained and the back is facing inferiorly, and then the modified Prague maneuver can be employed. The modified Prague maneuver, the acoucha grabs the leg of the baby and then places the arm over the shoulder and flexes the baby over the maternal abdomen to deliver the head of the baby. The complications of assisted vaginal breech delivery include there could be damage to viscous, there could be fractures, femoral fractures, humeral fractures, there could be palsies, Erb's palsies, Klumpke's palsy, there could be transection of the spinal cord, there could be entrapment of the aftercoming head, there could be stillbirth, which can be due to asphyxia, intracranial hemorrhage, and also cord compression. I want to say a few words about entrapment of the aftercoming head. It's one of the common complications of assisted vaginal breech delivery. Now, for entrapment of the after-coming head, if one encounters such during breech delivery, what is needed for entrapment of after-coming of the head is appropriate uterine relaxation. To manage entrapment of after-coming of the head of the entrapment of after-coming head in breech presentation, the woman needs to be appropriately relaxed. Alright, so general anesthesia should be administered to the woman, and also uterine relaxation agent like nitroglycerin should be administered to the woman so that the uterus will be well relaxed, and then the maneuvers can be done to deliver the head. Now, if this maneuvers fails, there are some incisions that has been described called the Ducey's incision, in which incisions are made on the cervix. This will create more space, and then the head would be delivered. What are the factors opposed to assisted vaginal breech delivery? If there's lack of operator experience, if patient requests for cesarean delivery, if there's a large fetus, if there's severe fetal growth restriction, if there's prior perinatal death or neonatal birth trauma, if there's pelvic contraction or unfavorable pelvic shape that is determined clinically or with pelvimetry, if a woman has had a prior cesarean delivery, these are all factors that are opposed to assisted vaginal breech delivery. Then the third management option is cesarean section. Now, cesarean section for breech delivery was based on a particular trial called the 10 breech trial, which randomized women into breech delivery and assisted vaginal breech delivery. And from that trial, it was found out that women who underwent cesarean section had reduced perinatal mortality, had reduced neonatal morbidity. However, because they underwent cesarean section, they had increased maternal morbidity. The 10 breech trial, however, has come under several criticism. And some of the critics of the 10B trial include the fact that the 10B trial only included nulliparous women. Less than 10% of these women who underwent the 10B trial had, only less than 10% had pelvimetry. So for most of them, the pelvis was not actually adequate for them to have undergone the assisted vaginal breech delivery. And there was no strict criteria with respect to including women for this trial. Moreover, data from studies with low perinatal mortality did not show any difference between cesarean section and also assisted vaginal breech delivery. Then there are two French studies that also came out after the 10 breech trial: the premodal study, that's the presentation and mode of delivery study, and the Lilly breech study group. The premodal study found that there was no difference in perinatal mortality once strict criteria were used. And the Lilly breech study group also found that there was no excessive neonatal morbidity using strict criteria. Follow-up studies has also been done after the 10 breech trial, and some of the follow-up studies actually revealed that there was no developmental delay and no reduced intelligence scores in babies delivered vaginally. Now, based on these studies that came out after the 10 breech trial, most international organizations afterwards shifted their stance from cesarean section to external cephalic version and assisted vaginal breech delivery, provided the woman is well counseled about the risks. There are also other criticism of 10 breech trial includes the fact that it led to an increase in cesarean section rate and also led to a loss of skill for assisted vaginal breech delivery. Now, even though the fact that most women will opt for a cesarean section, the skill required for assisted vaginal breech delivery is also important. This is because of the fact that some women will still opt for assisted vaginal breech delivery. It's also due to the fact that some women will present late in labor. Some women may even present in the second stage of labor, where at that point, one may still have to conduct assisted vaginal breech delivery. The skill of assisted vaginal breech delivery is also important. This is because of the fact that even in cesarean section, these maneuvers, as described earlier, are also necessary to be employed during cesarean section in order to make delivery less traumatic. Some special consideration in breech presentation. Preterm breech delivery. If we come across a fetus that is breech and is preterm, how do we manage such a fetus? For preterm breech delivery, what has been advocated that it depends on additional age. Most authorities believe that less than 32 weeks, cesarean section should actually be offered to these women. Particularly the Society of Obstetrics and Gynecology of Canada recommend that less than 32 weeks, cesarean section should be offered for a preterm breech. This is because of the fact that less than 32 weeks, the head is usually bigger than the other part of the body. So if these women attempt an assisted vaginal breech delivery, the risks of entrapment of the aftercoming head is usually higher. But after 32 weeks, from 34 weeks, then assisted vaginal breech delivery can be offered for these women. Now, for unplanned breech in labor, what do we do if you come across a woman in unplanned breech delivery in labor? It has been said that routine cesarean section for women with unplanned breech in labor does not seem to offer any superior advantage over assisted vaginal breech delivery. However, if a woman presents with breech in labor, particularly advanced labor, what one needs to do is to make the woman to be aware of the risks involved in both assisted vaginal breech delivery and also cesarean section. All right. One also needs to identify whether there are any risks that may not favor assisted vaginal breech delivery. If there are no risks, this woman can actually be offered assisted vaginal breech delivery. So routine cesarean section for women who present late on a planned breech in labor should not be offered. However, one thing you must note that for breech presentation, the management calls for individualization of cases. So every woman must be taken case by case. Other method of management for breech presentation. Moxibustion is a traditional Chinese medicine technique that burns a cigarette-shaped stick called Artemisia vulgaris. This is also known as mugwort in Japanese. It has been said that moxibustion works by causing the fetus to have change in position. A recent Cochrane database review found that there is some evidence to support moxibustion use when combined with acupuncture and postural management. So it has been found that if women opt for moxibustion, if it is combined with acupuncture, it has been found that for men with breech presentation, compared to those who did not undergo moxibustion, there was a higher rate of a spontaneous version of the fetus converting from breech to cephalic presentation compared to those who did not undergo moxibustion. The second malpresentation I'll be considering will be face presentation. In face presentation, the incidence of face presentation is about 1 in 500 deliveries. The presenting diameter in face presentation is the submentobregmatic, which is also the same as vertex presentation, and the presenting diameter is 9.5 centimeter. The attitude of fetal head is that of complete extension of hyperextension. The denominator in the face presentation is the chin. What are the risk factors or causes of face presentation? It could be caused by fetal anomaly, like tumors of the neck, central nervous system anomalies. It could be caused by hypertonia of the extensor muscles. It could be caused by multiparity, prematurity, multiple nuchal cord, and of course, it could also be unknown. Face presentation can be said to be primary or secondary. Primary face presentation is said to occur if the face presentation is detected before labor, while secondary face presentation is said to occur if the face presentation is detected during labor. However, for most cases of face presentation are usually secondary face presentation, which means that they are usually detected during labor. This diagram just shows the normal presenting diameter, that is suboccipitobregmatic diameter, the vertex presentation, which is 9.5 centimeter. Then the second picture on the right, shows suboccipitofrontal diameter, which is the flex head, with diameter of 11.5 centimeter. Now this diagram shows face presentation with a presenting diameter of 9.5 centimeter, and it is said to be a submentobregmatic diameter. Diagnosis of face presentation. Diagnosis is rare prior to labor. Clinical suspicion can be confirmed with ultrasound scan, and intrapartum can be confirmed by palpating the landmarks on the face. It's important to know that this can actually be obscured by edema. And also it's important to note that face presentation can actually be confused with breech presentation, particularly for the uninitiated or for the inexperienced. One of the ways that we can actually differentiate between face presentation and breech presentation is that in breech presentation, the relationship between the ischial tuberosity and the anus is on a straight line. So the anus is between the two ischial tuberosity, whereas in face presentation, the malar eminences and the mouth form a triangle. So this is one of the ways we can use to differentiate between face presentation and breech presentation. For the management of face presentation, the position of the face presentation is pivotal and key to the management of face presentation. Face presentation can either be mento anterior, talking about the position now, it can be mento anterior, it can be mento posterior, and it can also be mento transverse. But most position is either mento anterior or mento posterior. If the position is mento anterior, if the pelvis is adequate, positional vaginal delivery is possible with mento anterior position in face presentation. However, if the position is mento posterior, then cesarean section becomes imperative for the fetus to deliver. And this diagram just shows phase presentation, and the first diagram to my left shows when the chin is anterior, and the one to my right shows when the chin is posterior. The brow presentation, this is the least common and the most unfavorable presentation. It has an incidence of about 1 in 2,000. The presenting diameter is 13.5 centimeter, which means that a brow presenting fetus will not be able to deliver vaginally. It is caused majorly by cephalopelvic disproportion, and it is diagnosed by palpating the roots of the nose, the anterior fontanelle, and the supraorbital ridges in labor. The management of brow presentation is cesarean section. And the presenting diameter for brow presentation is the mental vertical diameter with a value of 13.5 centimeter. In summary, we've looked at the three common malpresentation. We looked at bridge presentation, we looked at face presentation, and we looked at brow presentation. For bridge presentation, we've learned that individualization of cases remains the key, and the options of management for bridge presentation is external cephalic version, assisted vaginal bridge delivery, and cesarean section. But the woman needs to be counseled appropriately with the risks involved in all these options, and should be asked, and she should be made to make an informed choice. For face presentation, we have learned that delivery depends on the position of the fetus. If it is mental anterior, delivery is possible if the pelvis is adequate. If the mental position, mental posterior, cesarean section becomes the route of delivery. For brow presentation, we've learned that the presenting diameter is 13.5, and the cesarean section is the way to manage brow presentation. In conclusion, it is important to be familiar with the various abnormal presentation, the risk factors, and their management. I'll end by this historical quote. It is an undoubted truth that the several unnatural postures wherein children present themselves at their birth are the cause of most of the bad labors and ill accidents for which usually recourse is had to surgery. Thank you for listening.